To be here today, Dr. Lee Kaplan had to take 3 airplanes, changed the ticket 4 times, and I almost got crazy, thinking that he wouldn't come. Why I almost got crazy? That's not the first time that I glad to talk to him, but I said, everybody in Brazil is your fan. And he told me, no, you are the only one that has this disease. I'm not. Everyone loves you. And we're very glad to be with you here, and it's really an honor. Aproveitem, é uma aula maravilhosa, e a gente tem que estar muito orgulhoso de conseguir trazer um professor desse calibre para falar no nosso congresso. He's a medical doctor, but a different kind of medical doctor. He talks more about how to inspire to treat our patients. He will show lots of data, but it's beyond the data. Dr. Lee Kaplan, thank you very much. It's an honor to have you here.
Thank you. Thank you very much. Oops, a little loud here. Thank you very much for inviting me. It's a pleasure to be here. I'm not new to coming to Brazil. This is my 10th trip. And most of those trips were to São Paulo, a few other places as well. It's also a pleasure to talk to nutrology, because in the United States, we don't have nutrology. And because I spend a lot of time here and a lot of time in Chile, I know what nutrology is, and I have to explain it to everybody in the United States, which is fun. We have obesity medicine, which is different. And that's what I do now. I'm a hepatologist and a gastroenterologist, but I do a lot of work on obesity, and that's really my passion. Well, obesity has become very exciting. We have new drugs, we have many more things to come. But we don't really use our drugs to the best of our ability because most people, including me, don't understand obesity well enough. We don't understand how the drugs work. We don't understand why the drugs work. Just as an example, if you have no leptin, you have severe obesity. Everybody with no leptin has severe obesity. There aren't very many people, but if you do, that's a genetic problem. But if you treat obesity, regular obesity with leptin, you don't get any results. So you need leptin, but it's not sufficient to treat regular obesity. The only obesity that leptin treats is the kind where there's no leptin. And that's only about a few thousand people in the whole world. Now, if you knock out the GLP-1 receptor, if you just get rid of it, you don't get obesity. You don't need GLP-1 to have a normal weight and a normal fat. And yet, GLP-1 is the best thing we've seen so far for the treatment of obesity. So that makes no sense. You need leptin, but it's not good for treating. You don't need GLP-1, but it's very good for treating. What this tells us is that the regulation of body fat, which is what I think is really going on, is incredibly complex. And we're still learning a lot about it. And I suspect in 10 years, we will be embarrassed by how little we know today, just like today, we were embarrassed by how little we knew 20 years ago. And so let's get started. My first slide is up there. I've called my talk Evolving Strategies for Effective Obesity Care. But as Guilherme said, I'm going to talk a little bit about some of the biology as well. So what is obesity? Well, there are definitions of obesity. And I hope halfway through this talk, I surprise you by telling you what obesity is not. But that'll be in a few minutes. Well, the World Health Organization says that obesity is a disease characterized by abnormal or excessive fat accumulation that presents a risk to health. I don't agree with this definition completely. It is a disease, It's frequently characterized by excessive fat. But abnormal fat, there are other diseases that are abnormal fat. Lipedema, lipodystrophy, those aren't obesity. Those are just other diseases of fat. So abnormal fat doesn't make any sense. I would argue that it's a disease of abnormally distributed fat. Fat in the liver, fat in the heart, fat in the pancreas, fat in the kidneys, or excessive fat accumulation. If you have fat in the wrong place, you probably have obesity. We know from our colleagues in Asia, they may have not too much fat total, but they have it in the wrong place, too much visceral fat. And of course, if it's abnormally distributed or it's excessive, it does cause abnormal problems later on that present a risk to health. So I haven't changed much. Another definition of obesity, which many people use, is that it's a complex, chronic, relapsing, and progressive disease. I don't agree with this one either, completely. It is complex. Just that leptin and GLP-1 story proves that it's complex. The regulation of body fat is complex. It's chronic for sure. Is it relapsing? I don't think so. Why? Because a relapsing disease is a disease that by itself gets better, gets worse, gets better, gets worse. Think about autoimmune diseases. Think about multiple sclerosis, Crohn's disease. Gets better, gets worse. Obesity doesn't get better, gets worse. You try to treat it and then it comes back. That's called relapsing. That's not relapsing, that's failure. That's our failure, not the patient's failure, our failure. Is it progressive? We don't know. It looks progressive. People get bigger over time. But if there are any endocrinologists in the audience, they know that just having a high sugar doesn't mean diabetes is progressing or high hemoglobin A1C. It could be that we're just not treating it very well. And only when we have markers of beta cell function can we really prove that diabetes is either progressing or not progressing. Those markers of beta cell function are independent of today's sugar or today's hemoglobin A1C. You can tell progression independent of failure to control. In obesity, we don't have an equivalent marker yet. We don't even know which part of the brain causes obesity. So therefore, we can't distinguish progression from failure to treat, or treatment failure, meaning that over time the treatment fails. So we have to keep that in mind. It might be progressive, it might not. So it's a complex, chronic, maybe progressive, but probably not relapsing disease. So why is it a disease then? It's a disease because the body is not regulating fat correctly. And the body normally regulates fat, as I'll talk about in a few minutes. By itself, with no complications that we can define, and there are more than 200 known complications of obesity. But even without those, it causes pathology and diminishes health. And we'll come back to that too. It's a risk factor for those 200 diseases, but by itself it's a disease because something is wrong in the body. That's what makes it a disease. Keep that in mind. Diseases, there's something wrong inside the body of the patient who has the disease. So whatever the cause is, whether it be the environment or the food or the stress or the speed of life or drugs or whatever, the final pathway has to be internal to the body. That's a hard concept, that we say it's a disease because of the environment, genetics plays a role. Think about nut allergies. Nut allergies barely existed when I was a child. But today, 8% of the United States population has a peanut allergy. Why? Because we think the environment changed. We think the environment's too clean and early in life. But if you have to carry an EpiPen, I don't know if you call them EpiPens here, if you have to carry an EpiPen to keep yourself alive, there is something wrong with your immune system. That's inside your body, even though it's a change in the environment that led to this epidemic. Obesity is the same thing. So the final pathway to obesity is internal to the body of the person with obesity. Well, I said all that, but do you really believe me? Is obesity really a disease? Most of the world doesn't recognize what I just said. Most of the world says this is a problem of human behavior, eating too much. Now, because the body normally regulates how much fat it has and where it has it, baby fat goes away all by itself, and baby fat is mostly in the arms and the legs. You don't need to put a baby on a diet. And as a boy goes through puberty and loses fat, and a girl goes through puberty and gains fat, it's in a completely different place from the baby fat. And again, you don't need to tell somebody to eat more to do that, or the boy to eat less. And as a woman becomes pregnant, that fat is in a third place, and it goes away by itself after the pregnancy and the lactation periods are over. Maybe not as much as you want, but it goes away by itself. You don't have to go on a diet. And as you go through menopause or as you age as a man, you are going to have fat in a fourth place. They're all different. And the body is constantly sculpting itself, regulating itself, and that regulation is what is wrong in obesity. This is a critical concept. So the normal regulation throughout the lifespan ensures that overeating doesn't cause obesity, because the body protects how much it wants. If you try to undereat or overeat, your body will protect what it wants at that period of time in life. Some people call it a set point. I call it a defended fat mass. Why? Because it changes. It's not set, but it is defended. So overeating doesn't cause obesity, but if you have obesity, for whatever the reason, it causes overeating so that you can gain the weight. Well, in obesity, the regulation is disturbed, but not the defense. This is a critical point. In other words, the body knows how to defend, but it doesn't know how to regulate correctly. If you have a heating system in here or an air conditioning system, the air conditioning system feels comfortable right now, but the air conditioning system is defending this, because when you all came in, you made it warmer, so the air conditioner had to make it cooler to keep the temperature the same. The defense is fine. If I turn the air conditioner up to 40 degrees, it's set wrong, but it will defend the 40 degrees. That's the obesity is defending the wrong thing, but not failing to defend. Very important point. So mindless eating doesn't make any sense, because if you mindlessly ate, if you overeat, even purposefully or mindlessly, your body will defend where it wants to be. I'll show you how that works in both directions in a minute. So undereating doesn't fix obesity, because the body is set wrong. And so if you try to undereat to fix the obesity, the body will push back. That pushback is called metabolic adaptation. And in humans, metabolic adaptation also includes appetite regulation. It will make you hungrier, crave more, have food noise, do all of those things to push back. Fixing obesity, however, if you fix it biologically, physiologically, that will lead to undereating temporarily, and then eventually you'll stop undereating because you'll find a new plateau. We'll come back to that later. These conclusions have critical implications for the long-term control of obesity, because what we have to do is fix the regulation, not tell people to eat less, because that doesn't work in the long term. Works in the short term, but not the long term. So what does calorie restriction do for us? And I call calorie restriction non-physiological weight loss. Well, if you study animals and people who undergo just calorie restriction, no change in the diet. We're not talking about a healthier diet. We're talking about just eating less of whatever you were eating before. Your energy expenditure is going to go down, proven in an article in the New England Journal of Medicine in 1995. Your appetite's going to go up. Your hunger is going to go up. Your craving is going to go up, reward-based eating. Your food noise is going to go up, and your satiety is going to go down. All of that's going to make you eat more in response to calorie restriction. Your stress will go up, and the hunger hormone ghrelin will go up, and the satiety hormones, the fullness hormones, GLP-1, PYY, CCK, and amylin will all go down. So all of that's going to push you to eat more. So calorie restriction pushes you to eat more. That's the defense. That's metabolic adaptation. Well, there was a show on TV 20 years ago called The Biggest Loser. Biggest Loser probably was the person who got into trouble for having the show. And in that show, they took people who had severe obesity and they put them on treadmills, and they had an exercise therapist pushing people hard and hard. And a lot of people lost weight, and the people who lost the most weight won the prize. Now, the reason they lost weight, though, when you study those people, is because they were encouraged to eat less. You don't lose much weight just by exercising without eating less, and so therefore but who would want to watch a television show where you watch people eat less? Silly. So therefore, what you would do is you would put them on the treadmill, and Jillian Michaels would scream at them, and they would sweat, and they would cry, and they would do everything, and so then it was a television show. It's kind of abusive television show. But everybody who lost weight on that show gained an average of 90% back, but some people gained 80%, some people gave 120%, but they gained it back over time. So why did they gain it back? They gained it back because when they were eating less, in some cases drinking less, they activated metabolic adaptation. They became hungrier, and they conserved energy. And so you can see here the physiological forces were building up for them to regain the weight because the defense is fine. Their obesity comes from setting the level incorrectly, not from defending it wrong. And so as soon as the show was over time, that force to push them back up, in fact, took hold. Some people regained the weight within 90 days. Other people regained the weight over a period of 5 years. That's pushing back up. So when you look at calorie restriction, I showed you where the arrows go this way. If you look at obesity medications today, the arrows all go in the opposite direction. Every arrow, energy expenditure goes up a little bit, not very much, a little bit, but it doesn't go down. Appetite goes down, stress goes down, the hormones change in the opposite direction. The body wants to lose the weight. You are fixing the problem. You're not completely fixing the problem, you're sort of overriding the problem. You're treating the problem. You're not making it go away. So look at that, how the arrows go in the opposite direction. And keep that in mind. Calorie restriction, you're fighting something, your body fights back. Obesity medications, your body isn't fighting back because it is responding to the medications by changing its physiology, by correcting the problem. I'm going to show you one piece of data from animals. It's the only animal study I'm going to show, with semaglutide. And in this study, they took a bunch of animals, and one group of animals, they had obesity, and one group of animals, they just let them continue. They just ate what they wanted, and they were eating the diet. And you can see those are in gray. And then in the second group of animals, in blue, they gave them semaglutide. In the third group of animals, they limited what they could eat. So they put them on a calorie-restricted diet. In the first two animals, in the semaglutide animals and the placebo animals, they could eat whatever they wanted. But in the calorie restricted, they were calorie restricted in a very careful way so that the black curve and the blue curve were the same. That was by manipulation, by experimental manipulation. The question was, what happened to energy expenditure? And what happens to energy expenditure is you see that when they are restricting their food to lose the weight, their energy expenditure goes down. The body is defending it. It shuts down energy expenditure to push back up. But when you give semaglutide, it doesn't go down very much. In fact, it really doesn't go down much at all. And the animals are getting thinner, so therefore a little bit will go down because the animals are getting thinner. But other than that, it's really not going down. So physiological correction of the problem, as you see with drugs, you also see the same thing with bariatric surgery, by the way. It doesn't work by restriction, it works by the same physiology, is very different. Okay, so I just told you what obesity is and how to fix it, but I haven't told you what's not obesity. So let's look at the opposite side of the scale. Remember I said overeating doesn't cause obesity, that's a mistake on this slide. I was copying the slide. Overeating does not cause obesity. Obesity causes overeating. So what about overeating? Well, as I've shown you, this is what you've already seen. Now let's do something else. Let's talk about purposeful overeating. Let's try to get fat. So when you purposely overeat, it looks a lot like medications. Energy expenditure goes up, appetite goes down, satiety goes up, in the case, stress is the only thing different. Stress goes up. When you try to gain weight purposefully, it's actually quite stressful. But the hormones do exactly the same thing. So actually, purposeful overeating looks a lot like what medications do. Well, that's a little weird. So we have an example of that from the movies. Robert De Niro, when he was younger, played a boxer in the movie Raging Bull. I don't know if anybody's ever seen Raging Bull. Anybody ever seen Raging Bull? It's a good movie. It's an old movie, 40 years ago. And this is what he looked like at the beginning of the movie, in the movie. And this is what he looked like at the end of the movie, in the same movie. He gained 40 pounds, which is about a little less than 20 kilograms. In this lower picture, does Robert De Niro have obesity? Raise your hand if you think Robert De Niro has obesity in this picture. You know, you guys are from Brazil. I never saw a shy group from Brazil before. So most people say, how many people don't think he has obesity? Couple of crazy people in here, right? So here's my answer. No. Why doesn't he look like he has obesity? Who thinks he looks like, even if he doesn't have it, who thinks he looks like he has obesity? Yeah, he looks like he has obesity, but he doesn't have obesity because there's nothing wrong with his regulation of body fat. In fact, he had to eat 6,000 calories a day to gain that weight. To maintain that weight during filming, he had to eat 4,000 calories a day because his body was pushing back in the other direction. So he was overeating. He was doing the exact opposite of what was going on in The Biggest Loser. He was overeating, but his body didn't want him to have obesity. It wanted him to be normal. So it pushed down. And as soon as the movie filming was over, well, who would have, I like this interaction. Who would have put him on semaglutide if it was true today? Number of people. In those days, we had phentermine or other things. He didn't get put on anything. He was just told to eat what he wanted. And within 6 weeks, he had lost all but 5 of the 40 pounds, all but 2 of the kilograms that he had forcibly gained. Without trying. He just ate what he wanted. He wasn't hungry. So the fundamental question, whoops, I'm going to come back to this in a second. The fundamental question is why doesn't he have obesity? Why am I saying he doesn't have obesity? I'm saying he doesn't have obesity because his regulatory system is fine. He just tried to abuse it by overeating. But when he allowed his body to do its job, his body did his job correctly. It defended a normal fat mass and a normal weight. So if I show this slide, to people in the United States, I guarantee you that 99% of people will say he has obesity. So you guys should be congratulated for some of you saying no. But he doesn't have the disease of obesity. He doesn't have a disease. The only disease he has is self-abuse for gaining the weight, but that was for his job. If you understand why he doesn't have obesity, then you're beginning to understand the biology of obesity. Even though if you say he has obesity, it's because he looks like he has obesity. We spend a lot of time saying that thin people sometimes have obesity, thin-looking people, because they were treated or because they are from South Asia or whatever. Here's the opposite. This is somebody who looks like he has obesity. He has fat. He's not Arnold Schwarzenegger. He has fat, but he put it there. His body didn't put it there. All right, so the fundamental question now, I'm going to stop with the biology and I'm going to go on to the clinical. The fundamental question now is, let's look at obesity from a clinical perspective. Where should obesity be treated? Should it be treated in the healthcare system, which is where we all work, or should it be treated in the commercial environment where companies like Weight Watchers and Noom and Golo and other companies work? What's the best place for it? If it's a disease, it probably belongs in the healthcare system. It's really a disease. Well, what's the purpose of healthcare? So now we're not talking about biology now. We're talking about the purpose of healthcare clinically. And it's to relieve suffering arising from disturbances in the human body. From symptoms, if you have a headache, you want it gone. If you can't see, you want to see. From disability, and from fear of all the things listed here. Complications, dying, developing a disability. Not being able to participate with your family or friends. And obesity causes suffering in every one of these ways. And you guys have patients with obesity. Some of you have friends and colleagues with obesity. They will tell you how it causes suffering. So relief of suffering from obesity-induced symptoms, disability, and fear falls squarely in the responsibilities of normal healthcare. And that's exactly what we all do, is normal healthcare. Obesity belongs in normal healthcare, even if it's not there very well right now. So what are the goals of obesity treatment? The goal is weight loss only because it improves health and it relieves suffering. If we think about it from the patient's point of view, they want to lose weight because they're suffering from the weight, whether it's psychological suffering or diabetes or cancer or heart disease, they're suffering. They're suffering from the social implications. So we want weight loss to be one of those things because that's number one, what the patients in part are suffering from, excess weight. We want improvement in the symptoms of obesity, and I'm not going to spend a lot of time on this, but ingestion-related symptoms, appetite-related symptoms, hyperphagia, being hungry all the time, craving, food noise, never getting full after a meal, food obsession. All of that is ingestion-related, but also physical, the inability to walk up a flight of stairs without getting short of breath, even though your heart is fine and your lungs are fine. That's obesity. And of course, the emotional symptoms, the dysphoric symptoms. Not because of the obesity, but because of the way society treats you if you have obesity. But those are still symptoms. Embarrassment about eating in public, embarrassment about being in public, unwillingness to interact with others because you've been stigmatized or in some ways abused. Of course, we want to improve the complications of obesity because even though obesity is a disease without the complications, when it causes complications, it makes it worse. So we want to improve those. And we want to prevent future complications. These are the goals of treating obesity. And weight loss is important, but again, you see it's only a small part of the slide. Okay, well, what prevents people from getting care within the healthcare system? I said, if we say it should be there, why is it not getting there? Well, there's a misperception that obesity is not a disease, but merely a risk factor. And we are just as guilty as everybody. There's an expectation that management of obesity is within the ability of somebody who has it, and delegation of that responsibility to the patient, and acceptance of the responsibility by the patient because they've been told their whole life that it's their responsibility. So they accept that and they don't fight back. When HIV became an epidemic in the 1980s, people with HIV fought back. That's why we had progress. People with obesity don't fight back as much because they've taken the responsibility, internalized it. There's widespread weight-related stigma, I've already mentioned that, and discrimination against people with obesity, which leads to blaming the person. And many healthcare providers are not immune from that. There's a perception of weakness and self-blame among people with obesity themselves. They feel weak. They feel like it's their fault. And it leads to delays in seeking care. So even if care is available, they delay in seeking it. In a study that I was involved with, it was the average 7 rounds of weight loss and weight regain before they sought help from a physician. 7 rounds. There's no requirement or meaningful expectation for healthcare providers to take care of obesity. Everybody in this room wants to. I certainly want to. But the medical community at large is so busy and so burnt out that adding one more thing, particularly one more thing that affects 60 or 70% of their patients, seems like too much of a burden. You don't get to say the burden of breast cancer is too much, we're not going to take care of it in our center. That's not a choice, but obesity is still a choice. And of course, there's inadequate education, time, and the workforce needed to address it. Obesity specialists in the US, nutrologists here, endocrinologists here, there aren't enough of you to take care of all the obesity in Brazil, no matter how hard you try. Well, good news, of course, in the middle of all this is we're in the midst of a revolution in obesity care. Surgery has been good for 50 years. It's gotten much safer than it used to be, but it is about the same, about a 30% average weight loss. Lifestyle, it's not shown here, but it gives you an average of about 4 to 5% weight loss over time. And drugs were about the same as lifestyle, and the drugs had complications and risks. And so you see, for the first 40 of the last 60 years, drugs were no better than lifestyle. But about 15 years ago, combinations of therapies and stronger therapies, safer therapies, that could be used long-term. Most of the therapies before in generation 1 were short-term therapies. But in generation 2, they became long-term therapies, at least 2 years of testing. And now with generation 3, with the advent of semaglutide and tirzepatide, and all the drugs shown on the right, there are now 120 different drugs in development right now for treating obesity. You can see where we are. And the early data on retatrutide that have been released by Lilly show up to, at least in Triumph 4, one study, 28.7% average weight loss. 28.7. That's better than a sleeve gastrectomy. So we have had this revolution. I'm not going to belabor it, you already know that. But I want to teach a few things about how we use these drugs because I think they're important. The step 1 and the step 3 trial were identical designs. There was placebo and there was semaglutide 2.4 milligrams per week. But in the step 3 trial, in both arms, the patients received much more intensive behavioral therapy. This study was done at the University of Pennsylvania, where they have a lot of experience doing intensive behavioral therapy. And the goal of that therapy was not only to tell people to eat less, but to really encourage them hard to eat less than they even wanted to on the drug because they had to be on a 500-calorie deficit diet. And what happened in step 3 versus step 1 is shown in these next few slides. What you see here is these 2 yellow bars are parallel. So when you told people to eat even less than the drug made them eat, you were doing calorie restriction plus physiology, they lost weight faster. But at the end of the study, 2 things were happening. One, they lost only 1% more weight, as you can see here by the green bar. but they were already beginning to gain weight because they were the body was pushing back against those extra calories that we told them to lose. The calories that they decreased their appetite for, that's physiology. But the extra ones that we told them to do, or that the investigators told them to do, they're already pushing back. Notice how it looks like an airplane landing on the left. It doesn't look, that's not the airplane I want to be on the right. So therefore, you can see it's smooth because the patient is responding to the physiology of the drug, the pharmacology. You can say, well, maybe this was not a very good trial, but look what happens with the placebo group. This is a group that really knows how to do these trials, and the placebo group, they lost a lot more weight if they were in the intensive behavioral therapy. So in the absence of a physiological way to lose weight or a pharmacological way, you can tell people to lose weight. They're still starting to gain weight at the end of the trial, but they're losing more weight. But in the presence of physiological or pharmacological weight loss, you don't need to tell people to eat less. You need to support them. There's a lot of work for the dietitians and the psychologists, because obesity is a little bit like cancer. It has an adverse effect on nutrition. It has an adverse effect on mental health. And when you treat the obesity, it can be even worse, just like cancer. And so you have to have support from it. So it's a change in responsibility for the dietitian and the mental health worker, and perhaps for the nutrologist as well. Still critically important work, but the focus is not losing the weight now. The focus is allowing the patient to benefit from the therapy. And of course, you need to treat for a long period of time, and you know these data. If you stop the drug, the patient will regain the weight. There is no way to substitute by telling people to eat less. And the only reason that these people didn't gain all the weight back is because it's a study, you had to come off the drug. They were begging for something, and they were put on other drugs, older drugs, they were put on diets, and eventually they probably would have gone back to the gray bar, the gray curve. Well, progress in our management of obesity-related diseases is also part of the new era. We used to say that obesity was associated with a bunch of diseases, 200 diseases, and we called them comorbidities. That's the word we used because they were related to each other in some way, but we didn't know how. And over the last 20 years, we've recognized that actually obesity can cause some of these diseases, and we call them complications. And we should distinguish between complications that come from obesity and correlated diseases, which are comorbidities. And in some cases, they're not really diseases. The social effects, the economic effects of obesity are pretty powerful. I call those consequences. They're not really complications, they're not diseases. But now we can say that we can treat the obesity, and if the disease is responsive, that becomes an addressable obesity complication or an obesity treatment target. And we're beginning to see that there are a lot of those. This is a list of all the diseases that are complications of obesity, because obesity contributes to their cause, that have been identified as benefiting from treating the underlying obesity. And for those of you, I'm probably the oldest person here, but for those of you who are even in the middle of your career or even early in your career, I want you to see the next part of this slide, which is the dates that it was proven that treating obesity improved the complications. Because what you'll see is in diabetes, the first date that was shown was with bariatric surgery in 2007. All of the other ones on this list, every other one on this list, was since 2022. If you went to medical school before 2022, you didn't know this. You couldn't have known this. And there are two at the bottom that are from 2026, and the year is only 1 quarter old. So what you can see is this is changing rapidly. And if you're interested and you want to talk to your colleagues or patients, or go to the Washington Post. Yesterday in the Washington Post, they had a summary of all the benefits of obesity, because some of them are not on here. Some of them haven't been proven yet. But these are the ones that have been proven by controlled studies. But numerous challenges remain, both scientifically and logistically, Because there's a broad distribution. We say that semaglutide in non-diabetic patients causes 16% weight loss. But this is the distribution of the weight loss with a diet, a low-carbohydrate diet. Some people gain weight to the left of that black line. Most people lose about 5% initially or 7% initially and then settle in around 4%. If you look at a drug like liraglutide, it looks like the diet, about a 8% average weight loss, but it's more maintained. But look at that distribution. There are some people in liraglutide who lose 25% of their weight, not very many. And there is still a bunch of people who gain weight on the drug in a controlled trial. If you look at the endobarrier, this is work done in Chile. You can see the endobarrier or duodenal liner. The average was higher, but the distribution was the same. And if you look at bariatric surgery, this is a gastric bypass distribution. You see the average is way higher, but there are people who don't do very well with gastric bypass. This is biology. What these curves show is variation in biology. There is a lot of need even for the new drugs, because if you look at tirzepatide, the best drug we currently have, the curve looks the same. The average is higher. 64, 2/3 of people lost more than 20% of their weight. The average was 22%. Almost a quarter lost 30% of their weight, bariatric surgery levels. But 3 to 4% lost less than 5%. And if you had diabetes, that number jumped to 20%. So 20% of people with diabetes on the best drug we have, the miracle drug, lose less than 5% or gain weight. Now, we also have challenges with respect to treating the complications by treating the obesity. The SELECT trial, as you know, caused a 20% decrease in the likelihood of having a major adverse cardiovascular event, 20% in people who already had had an event. But it occurs early in treatment. And when it occurs early in treatment, as you can see here where the green line in it is in the blue line, that's early before all the weight loss occurs. It suggests that there are weight loss independent effects, not just the weight loss doing it, but something about the GLP-1 is doing it. You don't know what it is. And if you look at all the different GLP-1 CVOTs that have been out there, this is a study that was a review article published 2 years ago, 2.5 years ago. What you see here, this is all diabetes patients because we don't have this many just for obesity. But on the x-axis, you see weight loss. And on the y-axis, you see how improved the MACE was, the major adverse cardiovascular events. And what you see, there's no correlation. You have albiglutide causing no weight loss and being almost as good as semaglutide. And you have something like lixisenatide or liraglutide having much less of an effect on cardiovascular outcomes. So the point being that there's no statistical correlation between how much weight you lose on these drugs and how much you improve cardiovascular outcomes. It's all over the map. And what that tells us is there's something about these different drugs that's different, and the effects are different, and it has to do with mechanism. So there are weight loss effects and there are weight loss independent effects, but we shouldn't call those weight loss independent effects. We should think about them as mechanism dependent effects. And so when the next drug comes out, that's a drug, say, with an amylin target, or a GIP target, or a glucagon target, or any other target, we're going to have to study whether it actually does the same job. Because it's not the weight loss, it's the effect of the drug. And so mechanism-dependent benefits of one treatment, one medication, may not carry over. And so we don't really know enough about this mechanism-dependent effects, not only for MACE or cardiac outcomes, but for liver outcomes, kidney outcomes, sleep apnea outcomes, pregnancy outcomes, et cetera, cancer outcomes, et cetera, et cetera. So as we explore treatments of more and more of the complications of obesity, we have to measure them against important clinical outcomes, and we have to determine whether the effects that they cause, the benefits that they cause, are mechanism dependent or weight loss dependent. So what do we need for new medications going forward? We need an improved average efficacy. the ability to rescue suboptimal responders, the people to the left side of those curves. We need improved ease of use for the patients. Greater tolerability, simpler or no ramp-up requirements, oral administration is coming, longer acting, lower price is already here. The price of semaglutide in India as of this week is between $20 and $40 per month. $20 to $40. So it's finally come down. We need to increase ease of use for prescribers. It takes an enormous amount of time to prescribe these drugs because you have to escalate them, and most people don't. Most primary care physicians and other providers don't escalate. Patient gets intolerant, they have nausea or vomiting, they say, well, you didn't tolerate the drug. Patients tell me this all the time. So they stop the drug, it's easier. We need to preserve muscle and bone mass. And then we have to determine what the preferential benefits are for the different obesity complications. But developing drugs is not enough. In comparison to the number of patients that you all have to treat, adequate care of obesity and related disorders is scarce for all the reasons here. Not enough of us, not enough drugs, not enough finances. Equitable access is not what we have. We have rich people being able to get the drugs, but not poor people. What we need is a new model of care where we can scale care to the need, because if it's a disease, we should be treating it. We need new training and reorganization of the workforce. We need patient prioritization by clinical need. And we need a more efficient care model that takes less time to treat the patients effectively. So if we want to treat obesity more effectively, we have to understand why it's a disease. And that's what I've tried to explain. We have to understand the goals of therapy, including weight loss, but with a greater focus on improving health and relieving suffering, as we discussed. We have to fully understand the barriers to effective obesity care, which I didn't spend a lot of time on, but I think you already know a lot about that. And most of all, we have to focus on the patient, keeping their needs, even if their needs are biased because they've absorbed the responsibility and the guilt. That's not an excuse for us to buy into that guilt. It's an excuse for us to teach them the real story of obesity. So I'll end with a quote from an author named Charles Eisenstein. It's almost Einstein. This is Einstein, but that's Eisenstein. The world as we know it is built on a story. To be a change agent is first to disrupt this story, the existing story, and second, to tell a new story, so the world people have somewhere to go. You can't just destroy the old story. You have to have a new story. So I'll ask you, what is the current story of obesity in the real world, not in this room, in the real world? How does it need to change? And finally, I'll challenge you. What's our role, yours and mine, to promote that change? And if we don't do it, then we should expect in 20 years that with all the new therapies that we have, we won't really have changed the life course of people with obesity. That's our job. Thanks very much.